Welcome everybody to Health Freedom Summit. This is probably my favorite interview that we're going to do. It's hard to pick a favorite, but this is a pet topic that I have: reproduction, infertility, and we have probably the best candidate to the best expert on this topic in the country. I would argue that. So Dr. Craig Turczynski, thank you for joining us. You are a PhD trained reproductive physiologist. You trained at Texas A&M University, and you pursued your postdoctoral fellowship in reproductive endocrinology at the Women's Research Institute in Wichita, Kansas. And after that, you directed the IVF, endocrinology, and hormone assay labs at LSU Medical Center in Shreveport, where you also served as assistant professor and embryologist for the Department of OBGYN. But you left that role in 1999 because you noticed some problems. I'll let you speak to that later. But now you advocate for fertility awareness-based methods, restorative reproductive medicine, and you do that in the capacity as Director of Strategy and Scientific Affairs for BOMA USA, which was essentially founded by Doctors John and Evan Billings, who are personal heroes of mine. And their research led to the discovery of natural family planning, and their work, basically all fertility awareness based methods are based off of their work. So I'm really excited, Craig, to have you, and we are going to talk about infertility. Yay!
Oh, thank you, Alana. Oh, I'm very honored that you'd asked me to speak about this. And when I read the data, I find myself sometimes wanting to root for one side or the other. I do have a bias, but I tried my best to be neutral, and I'm taking that position in this particular discussion. That's why I'm concerned mostly, and other scientists have been concerned about the whole integrity of the medical research system. All right, there's human nature, and that's why there are things such as prospective, randomized, double-blind controlled trials. Right? We do those things so that we maintain, so there's not bias in the research. And that's extremely important. In our discussion today, what I'd like to do really is accomplish three things. First, present evidence for a plausible mechanism of reproductive harm with the vaccine. That's out there. Then demonstrate how the main reproductive health organizations like the American College of Obstetrics and Gynecology and the American Society for Reproductive Medicine very early on took a very aggressive and premature approach to promotion of the vaccine in pregnant women. So we're going to go through the timeline a little bit to demonstrate that. And then we could talk about some of the studies that have been published on the effect of the COVID vaccine on reproduction. Some of that is complicated, especially when you get into the miscarriage or pregnancy loss data. And it's very fluid. So it may be good to come back at some point and just talk about pregnancy loss in regards to the COVID-19 vaccine or even the virus itself, because you always have to weigh the risk between the two. So
I feel like, I said, yay, infertility. Infertility is so sad. And I didn't mean to be, what's the word? Insensitive towards people who are going through that, but I'm excited to go through the data, because first you have to name the problem before you can find solutions, and I'm just excited to talk about potential solutions because we're going to get to that too. So thank you for going over the data with us. And
yes.
So what did the ASRM and those two organizations say so that was so aggressive?
Yeah, so if I may, I'm going to talk a little bit about the potential mechanisms first, the potential mechanisms of harm, reproductive harm. Okay, there's two things that have really been discussed, and this is important towards the mindset of the main reproductive health organizations. The first one is that it's related to the spike protein. The spike protein on the surface of the virus, which is also what's been developed as a way to treat or vaccinate people through that spike protein. The spike protein sequence, the amino acid sequence, is very similar to a fusion protein that's important in cell fusion in the reproductive system, especially implantation. It's called syncytin 1. So there's a similarity between those two, and the thinking was that if you build up immunity or antibodies to that protein, that it'll then attack the protein that's important for implantation. I think that is a very remote possibility. It's not highly probable. And the reason for that is because the homology between those two proteins is only 4 amino acids. And then there's also some data that the American Society for Reproductive Medicine published that indicates that that's not the case. What's more likely is the fact that the spike protein itself that your body makes when these messenger RNA vaccines are injected into you, your body makes the spike protein, is biologically active. So in order for that to be the case, three things have to be satisfied. One is that the vaccine, when injected into your arm, so it's injected into your deltoid, has to circulate throughout the body, right? It can't just stay in the deltoid. It has to circulate throughout the body. Number two, it has to bind to cells just like the virus does. And the mechanism that the virus uses to bind to cells is what they call the ACE2 receptor. The ACE2 receptor is not really a receptor. It's actually an enzyme system that tissue uses to locally control blood pressure. But somehow the virus has adapted to make that a receptor. So that's where it binds and enters the cell. So the spike protein has to be able to do the same thing. And number three, in order for it to possibly affect the reproductive system, it has to be shown that these ACE2 receptors are distributed throughout reproductive tissue. Mm-hmm. Okay, so there is proof for all three of those things. Not again to say that there's definite harm, but that there's a plausible mechanism. So the first one, and many people have heard about this, is, again, assuming no controversy, right? This is a document that came from Pfizer. Apparently it went to Japan and then it was somehow translated and leaked. And now people have this pharmacokinetic study data.
Pharmacokinetic.
Right? So this is data from Pfizer that demonstrated that when they injected the messenger RNA into rats, into the muscle of rats, that it got distributed into the liver, the spleen, the adrenal gland, and the ovaries. So the concentration was highest 8 to 48 hours after administration. Now, these were rats, of course, but that's why we do animal studies, is typically what happens in animals happens in humans. So there is evidence that when the vaccine is injected into the muscle, it doesn't stay in the muscle. It moves around the body. Okay. Number two is, can that spike protein bind to the cells just like the virus can? This was a paper published. It's a review article. So that means they reviewed a number of research papers to come up with this opinion. It's not just one study. It was published out of Georgetown University with collaboration from a laboratory in the Ukraine. And just to summarize their findings, the SARS-CoV-2 spike protein can by itself trigger cell signaling that could lead to various biological processes. In addition to cardiovascular cells, other cells that express ACE2 have the potential to be affected by the SARS-CoV spike protein, which may cause adverse pathological events. So that's number 2 that's been satisfied.
Can you tell us the name of that study and maybe the author,
Yeah.
the lead author?
Yeah, absolutely.
Thank you.
So this 2 authors, Dr. Suzuki and Gashka, I think is how you say that. And the name is, or of the title is SARS-CoV-2 spike protein elicits cell signaling in human host cells, implications for possible consequences of COVID-19 vaccines. It was published in January of 2021, which was just after the vaccine was authorized for emergency use.
Wow. Wow. Thank you.
So that's 2 of the 3 things that need to be satisfied.
Okay.
The third one is the ACE2 receptor in reproductive tissue. This is another review article. So again, reviewing lots of research. And it's out of China, but it was published in Molecular Human Reproduction. And it was published May. So their findings were the available evidence of all these studies suggests that ACE2 is widely expressed in the ovary, uterus, vagina, and the placenta, all reproductive tissue.
That's everything. What else is there?
Yeah. And ACE2 is important for regulation of follicle development, ovulation, luteal function, and endometrial changes.
That's huge. That is huge.
So 3 things have been satisfied. There's another study here that gets in more specifically about endometrial tissue. The ACE2 protein highly expressed in human endometrial stromal cells during the secretory phase, which is the phase post-ovulation when the uterus is planning for and preparing for implantation. It's also essential for human endometrial stromal cell decidualization, which is part of the process, the transformation of the and formation of the placenta, important for implantation.
Okay. I was going to say decidual what? The placenta. Okay. So
yes.
That when people were talking about in the beginning, when concerns about reproduction were happening, you heard a lot about the placenta and that
Right.
it was going to cause harm to placenta development. So that would suggest that was a proper concern.
Yes, it just it doesn't prove anything, but it demonstrates that there is a reason for caution, right? And that's how the medical scientific industry needs to exist. You need to question. You see observations, previous research. You form very informed questions, and then you set up experiments to test hypotheses to answer those questions. So if all this information exists, does it not make sense that there should be a concern?
Right. Right. Obviously, we need to talk. Mom,
Right.
Dad, we need to talk. Okay.
So but back to your question now. That leads to the demonstration that given that this information existed, right? It all existed around the time that COVID was becoming, before COVID existed, and then while we were first starting to sort out the disease. The U.S. Department of Health and Human Services, Food and Drug Administration, and a couple other governmental centers, they put out a document in 2018. So this is before COVID. And this kind of demonstrates what the norm is. What is the norm for experimentation and use of drugs in pregnant women? Okay, the title is Pregnant Women, Scientific and Ethical Considerations for Inclusion in Clinical Trials, Guidance for Industry. Okay. And I like to read the exact words, so it's not me. It's not coming from me. In the interest of promoting maternal fetal health and informed prescribing decisions during pregnancy, this guidance addresses the challenges of including pregnant women in drug development research. The reason for that is that extensive physiological changes associated with pregnancy may alter drug pharmacokinetics and pharmacodynamics, which directly affects the safety and efficacy of drugs administered to pregnant women. So the established norm is, if a medical device company, which I worked for many years, or a pharmaceutical company wants to have a drug that can be used for pregnant women or children, by the way, they have to specifically do studies in that patient population. And if they promote the use of their device or their drug for pregnant women or children without having those studies, they will actually be prosecuted by the Department of Justice. Company executives have gone to jail for that. And companies have been fined millions of dollars by the Department of Justice. Fined millions of dollars and put on corporate integrity agreements. So this is serious stuff, right? But before you can even do studies on pregnant women, you have to do a few other things first. You have to do studies on pregnant animals, and it has to be proven to be safe and effective in non-pregnant women, right? So you need those two things before you can even do studies. And the research has to hold out the prospect of direct benefit to the woman or the fetus. And if there's no such prospect of benefit or risk to the fetus, the risk has to be greater than minimal, not greater than minimal. So in other words, the risk of the treatment has to outweigh the risk of the disease. And we can make that argument that with COVID, what is the mortality rate of infection with COVID-19?
For young fertile women, next to nothing.
Right. So you could argue somewhat about the data, but definitely less than 1%. Right. So the risk to treatment has to be not greater than that. It cannot be greater than that.
Got it.
Another real interesting thing they point out in here is if the treatment is designed to benefit the fetus, then the man also has to give informed consent. So if the vaccine is being given to a woman to protect the fetus, is the man giving consent for that? That's the established norm.
For clinical research and for implementing these procedures. And let's just be clear, they have not done any of that.
Right.
They have not done any of it. So they are skipping all the protocol.
Correct.
So how do we sue? Where do we?
Yes, if the ASRM were a medical device company, they would be prosecuted. But let's talk a little bit about what they did. So December 16th, 2020, a number of organizations put out a joint statement. It included the American College of Obstetrics and Gynecology, the American Society for Reproductive Medicine, Society for Gynecological Oncology, Society for Maternal Fetal Medicine, a number of them, right? This is 5 days after the Pfizer vaccine was authorized. They said, it is our collective opinion after closely monitoring this situation that the benefit of COVID-19 vaccination far outweigh the risk. It is especially important in certain eligible patient populations, including pregnant women. Since the beginning of the pandemic, we have urged that pregnant and lactating people be included in the vaccine trials and research. Unfortunately, they were not. Okay, so throughout their press releases here, they made conflicting statements. They said that they recommend the use of the vaccine in pregnant women, and then immediately follow that with the statement that there's really no research to support that. This was the language by ASRM specifically, so they were bolder by themselves than they were with the group. They said that the task force does not recommend withholding the vaccine from patients who are planning to conceive, who are currently pregnant, who are lactating. This is 5 days after the release of the Pfizer vaccine, or authorization. We can't call it. It wasn't approved at this point. It wasn't
Still
clear.
not approved. Only the Comirnaty one, still to this day. So
Right.
I'm sorry to interrupt, please.
Patients undergoing fertility treatment and pregnant patients should be encouraged to receive the vaccination based on eligibility criteria. And then immediately follow it with, the lack of data about the vaccine during pregnancy should all be taken into consideration as patients make decisions regarding vaccination.
Okay. So how much power does this organization have? And as someone who's worked closely in the field of, OBGYN, is what they say the gold standard?
They are the authority, that them and the American College for Obstetrics and Gynecology, I would say, in terms of women's care and reproductive care in the United States. They are the authority. They have thousands of members. Those members follow the organization's guidance. So when they put out these statements, they're official statements that they're saying that the membership, all the practicing physicians, can follow these guidelines. This is kind of like the authority. So they have tremendous power, not only with their membership, but politically as well, because they are very active legislatively and lobbying. And so their power is immense.
And if you disobey their recommendations, could your career be profoundly disrupted?
Absolutely.
Interesting.
Absolutely.
Can I ask you, so there's been reports of women having irregular cycles. Can we talk about that? Or is there something else you wanted to say?
Yes.
Okay. So
Yeah, actually,
the symptoms that are being documented.
So lots of anecdotal reports, right, of things like abnormal bleeding even in postmenopausal women, disruption in the cycle. And as a trained Billings ovulation method teacher, you know that there are different types of bleeding, right? And you know that there are many things that can affect the cycle.
Yes.
There is actually a study that was recently published. So it was published this year, so January 2022. Association between menstrual cycle length and coronavirus disease. It's a good piece of the puzzle, right? They had nearly 4,000 individuals, about 1,500 of them who were unvaccinated, 2,400 of them vaccinated, 3 different vaccines. And they looked at what their cycles were like pre-vaccine and then post-vaccine. Okay, and they were able to do this because they were using the fertility awareness method called natural cycles.
Okay, so
right?
There's an app for that.
Yes, which you know, it's a good method. We promote, you know, the use of fertility awareness based methods. We don't say you only can use the Billings ovulation method, but there's strengths and weaknesses to all of them.
I love the
right?
Billings method. It's I love it. Yeah, but yes, okay. So they're charting their cycles, and they have these women who have been charting for either to avoid pregnancy or maybe they're trying to achieve pregnancy, and so they have all this amazing data, and that's how they were able to get this research.
Correct. So you can make the argument that using basal body temperature and a logarithm and self-reporting is not the best, right? It's not the prospective randomized and also prospectively looking at fertility like the Billings ovulation method does would be better, but this is a good piece of the puzzle. And in these the 2,400 vaccinated individuals, turns out there was less than a 1-day change in their cycle. So very little change overall in an entire vaccinated population that they studied. However, there was a group of 358 women who received both vaccinations in one cycle. So they had to be obviously vaccinated early in the cycle, which we know is the most variable part of the cycle. But then also vaccinated probably in the later part of the cycle. So that begs the question of, does it matter when they get the vaccine? What part of the cycle they're in when they get the vaccine? It's probably an important observation.
Wow. Right.
But also that there's 38 of those individuals that were vaccinated twice in one cycle that had what they called a clinically significant change in cycle length, 8 days or more. And this was statistically significant.
And how long were they tracking the data? 3 months after? Obviously, it's not years and years.
4 to 6 cycles.
4 to 6 cycles. Okay.
So tracked for 4 to 6 cycles. But as you know, if you are infected with the virus, some people have no symptoms. Some people have mild symptoms. Some people have serious symptoms, and some people die. Okay. I didn't do the math here, but I think that comes out pretty close to the same, about 1%, right? So about 1% of the women had a clinically significant change in their cycle length, and whether or not there's long-term consequences, we have no idea.
And we don't know who, there's no testing of if you're going to be one of those women. We don't have like, okay, everybody with blue eyes is going to die if they get this. We don't have any kind of data like that. You can't tell.
You can't predict.
Doing genetic testing beforehand.
Right. We can't predict.
Right.
Now, you can't forget that the virus itself can do the harm, right? So each individual really has to make the decision to weigh the risk between becoming infected by the virus and then subsequently being treated, by the way. You can't, if you're not being treated after getting the virus, then that's not fair either, right? Be offered all the treatments available if you get if you get the virus.
Mm-hmm. Can I ask another question, or is there something you want? I noticed on openvaers.com, it's a website that I like to look at that kind of simplifies the VAERS data, and they update it so it's easy to read. They reported that that there's been 3,903 miscarriages as of our recording, so early February. Have you looked at the miscarriage and stillbirth data, and do you have any comments about that and why that might be happening?
Yes. The miscarriage data becomes quite complicated. And this might be a reason, again, to come back and do a talk just on that alone. But I recently was able to get some of the raw data from the organization mentioned, and I haven't had a chance to dig into it at all. But you read some of the statements, and if those were to be broadcasted on TV every single day, like what was happening with the virus, I wager to bet that nobody would be taking the vaccine.
Great point.
But I asked them if there was a denominator to go along with that. And that becomes very complicated. So the reports are only a numerator, right? We don't know from that number of people how many were actually vaccinated. We don't know that detail. So that's very pertinent anecdotal data to say we should look closer here, right? And of course, pregnancy loss can be devastating.
Absolutely.
And it should never be taken lightly, which is the reason why we have these control mechanisms for doing studies on pregnant women. Right. But so the data on pregnancy loss, first of all, I have not had a chance or the ability to review any animal data that may have been produced. I'm sure there's some animal data where they've given the vaccine to pregnant animals, whether they're rats or mice. That has to be out there. Whether it happened before the emergency release or not, I don't know, but that has to be out there. I have not been able to review that. Also, there are some reports of increased severity of COVID-19 disease in pregnant women. I haven't had a chance to review that. I know those reports are out there. There are other reports to say that it's not any higher. And then, again, the question of whether or not those pregnant women are being treated and given the full opportunity to recover from infection by COVID-19. So that's out there as well. But we do know that pregnant women were not included in the trial. ASRM made that point quite clearly. But in April of 2021, this is a woman by the name of Victoria Mail. You may have heard that name. floating. I think she's been vocal about it. She's at the Imperial College of London in the UK. She published a letter to the editor, and also this is in Nature Reviews, April, and she presented some data here. Some of the people who participated in the early vaccine trials became pregnant, right, during the trial. And just to report, because the trend's pretty similar for all the vaccines, but for Pfizer, there was a little over 18,000 in the control group and 18,000 in the vaccinated group. There were, in the control group, 12 pregnancies that occurred, and one of them miscarried. And in the vaccination group, there were 11 pregnancies and no miscarriages. Mm-hmm. And again, the data was similar between these two. So at least through the vaccine trial, if somebody inadvertently became pregnant, it didn't appear to be a difference in miscarriage rate. Okay, one piece of the puzzle. Then there was the article by a large group. First author was Shemabukura, and it was published in New England Journal of Medicine, June of 2021. A lot of people are citing this paper for on both sides of the subject. And they looked at nearly 4,000 participants that enrolled in the Vacc pregnancy registry. 827 of them completed completed pregnancy, and 115 of them resulted in pregnancy loss, so about 13.9. The range of what is being reported as normal pregnancy loss is somewhere between around 11 to 20%. And that range, you could argue maybe that 20% is maybe not accurate, but anyways, let's stick with that for now. So that falls within the normal range. And they conclude that their preliminary findings do not show obvious safety signals among pregnant persons, but follow-up of large numbers of women vaccinated early in pregnancy is necessary to inform a maternal pregnancy and infant outcomes. Okay. Now, there's a problem with this data set, and I want to come back to it. This is a correspondence published in the New England Journal of Medicine, again, by a group of people, again, all on the behalf of the CDC. They again analyzed the Vacc COVID-19 pregnancy registry, and they had 2,456 participants, so a good number. 165 of these reported spontaneous abortion. And they concluded that the cumulative risk of spontaneous abortion between 6 weeks and 20 weeks of gestation was 14.1, which is normal. Okay, they did some quite sophisticated work with the data. They did what they call cumulative risk for spontaneous abortion. So it's called spontaneous abortion when it occurs early in pregnancy.
Okay.
So cumulative means that they look at what the pregnancy loss was from the 6th to 7th week, from 7th to 8th week, and so on, and they add them all up. Okay, so it's a very sophisticated way. And then they compared that to the data, and they graphed it, and they showed from the top lines here basically the trends were similar. Okay. So again, evidence towards there not being a risk. Another study, this one in November, using the Norwegian registry for first trimester pregnancies. So they have a registry where not only vaccinated but unvaccinated people report their pregnancy outcome. Basically, they had 13,000 pregnancies that were unvaccinated, 772 of them that were vaccinated. At the 5-week pregnancy window, and there was no differences between the two. Okay, so the ASRM in their later announcements were using this data to make very bold statements. Okay.
Okay.
However, I mentioned there's a problem with that first study, right? There was a publication by 2 authors out of New Zealand in Science, Public Health Policy, and the Law. And they addressed the same data that was published early on. And I'm just going to go to the original paper so I can try to explain. So there was 104 spontaneous abortions that occurred before 20 weeks of gestation out of 827 pregnancies. However, 700 of those 827 pregnancies, the vaccination occurred in 3rd trimester. So those should be ruled out, right? If you're looking at early pregnancy, you have to subtract 700 from 827, and you get 127. So 104 spontaneous abortions out of 127 equals 82%.
So 82% of pregnancies are ending in miscarriage or spontaneous abortion in the vaccinated.
That's what's being discussed. And that's what's being discussed in this paper right here. Very, very elegantly, I might add. Okay. So even though there's data that says it's not at risk, there is some question still arising. And again, remember, I'm taking a neutral approach here. I'm just looking at all the data.
But there's reason to believe they're massaging the data to make the vaccine look good.
None of this is prospective, randomized, controlled, double-blinded studies. You know what double-blind means, right? Double-blind means that not only do the subjects not know what treatment, whether they're being vaccinated or unvaccinated, and the researchers who are investigating the study don't know which group is the vaccinated and which group is the unvaccinated. Okay. And also, when a paper is published, there's reviewers, right, that have to approve that publication. The reviewers should not know who the authors are. So they're not biased in whether or not they accept the publication or decline the publication. These are all safeguards to promote the integrity of our research, medical research industry, if you will.
Thank you for articulating that. So integrity is gone by the wayside in regards to these particular ventures.
Absolutely.
I wish I could say I was surprised. Okay, I want to talk a little bit about infertility rates. I had heard that roughly 10% of the population suffers from infertility. Is that percentage still accurate? And can we make any predictions or make any baselines so that people can start keeping track of what infertility rates will become after 2021's vaccine campaign? Can you tell us what the baseline should be or what you have experienced in the last 20 years?
Yes, so I think most statistics have settled on that. About 1 out of 6 couples, or about 20%. 20% of couples experience infertility with, I like to break it down, a third. Third is from female, a third is from male, and a third is 50-50. I think the actual statistics might be 40-40, 20. 20 is mixed, but in that range.
Okay. So let's say someone took the COVID shot and now they're worried that they might be infertile. You and I have talked previously from in the past about IVF a lot. And most people would assume that if you're experiencing infertility or you're struggling to conceive, the first place you should go is to IVF. Can we talk about maybe why that might not be the best first place to go?
Yes.
And
yes.
I'd love to talk about natural family planning.
Yeah.
Yeah.
Yes. No. Thank you. I'm very passionate about this.
Me too.
Alana.
Yeah.
Because having seen the harm that is sometimes done to patients financially, psychologically, and physically through assisted reproductive technology, and then understanding the data of what happens to, in some cases, the women, their pregnancy outcome, right? Complications are all elevated. But then what happens to the children as well? Higher rates of congenital abnormalities, and what they're starting to identify now are what they call epigenetic changes. So not changes to the genes themselves, but how the genes are expressed. But it's not known if that is because of the procedures themselves, the invasive procedures that are being used. There's evidence to suggest that it is, or if it's because we're forcing pregnancy and birth from people who have illnesses that cause their infertility. It's probably a combination of the two. And what restorative reproductive medicine does is it works to try to first identify what those health issues might be. And it's very often an endocrine, related to, say, thyroid, adrenal gland, or some other endocrine organ function, that, or it could be metabolic, right? We know that diabetes is an epidemic. And so diabetes is the end stage of metabolic illness. Early metabolic disease sometimes is not really noticeable, but it does affect the reproductive system. So identifying those things and correcting them before they conceive is extremely important. Some of the data that's been presented by restorative reproductive medicine practitioners have showed that the rates of conception following treatment, even in patients who have already failed IVF, so these are very difficult patients, and older patients especially too, are almost the same as assisted reproductive technology. Now, it matters what the age and what the reason for infertility is, right? Restorative reproductive medicine doesn't have all the knowledge right now to treat everything. You can't treat severe male factor, most likely, especially if it's of genetic causes. But say azoospermia is the presence of no sperm in the ejaculate.
Mm-hmm.
It's unless that has to do with maybe an obstructive reason that can be fixed with surgery. The chances of overcoming that are very, very slim with restorative reproductive medicine. But it's because we haven't studied it either.
Mm-hmm.
Because of IVF and ICSI, where we can take a single sperm now and inject it into the egg and almost guarantee fertilization, the field has just bypassed treatment of men's infertility or recognizing what's causing their infertility. So I'm a big proponent of restorative reproductive medicine, and that's what's important. So in terms of the COVID vaccine and what it'll do to fertility rates, if the COVID vaccine or the virus itself proves to increase the overall lack of health of the population, then infertility will increase. We know that for sure. If some of the possible mechanisms I mentioned to you at the beginning, which all make sense and have not really been tested, if any of those prove to be true, where a certain number, maybe a proportion of the people that are vaccinated, maybe similar to the proportion of people who are vulnerable to the virus itself, are damaged. If they are damaged by the vaccine, then infertility will increase in that subset of population. It remains to be seen if that will be significant enough to move the needle globally to the entire population. But you can make the argument that organizations like the American Society for Reproductive Medicine and their membership, which makes money off of treating infertility, perhaps doesn't care that the vaccine is causing infertility because they have the tools to fix it.
Yeah, I hope that people who come to this summit start to get a concept or start to conceptualize the medical industrial complex a little bit. That's something that I care about our viewers, and I want them to understand that mechanism. You talked about human drive and human behavior, and the money plays a role in that. And so if there is a product that is increasing infertility, and then you have all of these healthcare operations and industries that serve infertile patients, and oh, by the way, each IVF cycle costs on average $10,000, and the failure rate is so high. I think it's like over 70% of failure rate for an IVF procedure. And then they do that 3, 4, 5 times. So you have now the infertile couple has invested tens of thousands of dollars to build the family of their dreams. Does it not make you question, doesn't that seem like it might be some kind of scam, or at least the ASRM might be getting rewarded in some way for an infertility increase? It just makes you wonder. That's my concern. Yeah. But I know that you're neutral and that you've got, I don't want to put words in your mouth in any way, but is not restorative reproductive medicine and cycle charting a much more cost efficient and even more successful way of is that not the first place people should go? Yes. Because the cost, is only a few $100s to learn how to chart, and then it's just much cheaper. Right. And the success rates are better. I forget the exact numbers. Maybe you can help us with that.
Conception rates using a fertility awareness-based method are going to range around the 80% mark.
80% success.
80% success, but that's everybody, right? That's fertile and infertile.
Yeah.
If you're infertile, It depends on what the cause of infertility is,
Right.
but and how old you are, of course. But it's going to be somewhere between 25 to 50%. And absolutely, before you would pursue assisted reproductive technology, you should try this. You should try this first, because as you mentioned, depending on which method you learn, it's only going to cost you a few $100s to learn it. And then you will possess that knowledge for the rest of your life. So as the woman goes through her reproductive stages, especially, menarche, so that period of time when there's lots of variability and irregular bleeding when you first begin to menstruate, then through your reproductive years, so that you can control or have some control over the number of children that you have. And then when you're entering into your post-reproductive years, help you make that transition to menopause. So understand what's going on. And during the whole course of that woman's life, she can also identify when there's a problem, when there's a health problem, because she knows what's normal. And so she can identify when it's not normal. And therefore go see a physician who's trained to be able to use that chart. There's very few, by the way, very few health professionals that have gotten any training in fertility awareness based methods and know what to do, have a trained eye to be able to look at that chart and know what it means.
I just want to insert here that BOMA, Billings Ovulation Method of America, is a go-to place to find those doctors. So we're going to put a link to BOMA USA underneath here. And so if people are looking for doctors who can help them with their chart and identify what the root cause of infertility is, right here is the place to start. It's a good place to start.
Yes. Thank you.
And we need more teachers, don't we? Don't
Yes.
we need more teachers to learn how to teach couples how to chart?
Yes.
So
yes.
You guys, BOMA trains teachers as well.
That's really what, we're a nonprofit, but nonprofits need to have revenue, right? Or they don't exist. We got a lot of donations from very generous people that believe in our mission. But then we also have to develop some revenue source. Our revenue source comes from training people how to teach the method. So we don't collect any revenue from couples, women who learn to use the method for their own personal use. We train the teachers that will subsequently teach those users.
And so if you have a healthcare practitioner or a natural health person or some, doulas, often they can tack on a natural family planning certification, or a Billings ovulation method certification, and add that to their natural healthcare business and services. So I know that there's a lot of those type of women who are succeeding in helping people.
Often the physician themselves aren't the ones that teach, right? They typically have to work with somebody else that can provide the more detailed one-to-one instruction with the woman or the couple. And so either their nurse or their medical assistant, or it doesn't even necessarily need to be an otherwise medically trained person to work alongside a medically trained person. But then also nutritionists, as you mentioned, natural doctors, many of the allied health professions have incorporated the Billings ovulation method or another form of fertility awareness based method into their practice.
And I guess that's why I'm mentioning it, is because this is a plea. This is an official plea to people who have natural healthcare services. Please consider teaching people how to chart their cycles, women how to chart their cycles. And the reason that I am specifically promoting Billings, not only is because it's the method that I was teaching before I got into the whole COVID Health Freedom Summit platform, but it doesn't require gear. So you can take it to Mother Teresa taught this to the poorest of the poor in Calcutta. So women don't have to buy stuff every month. There's no expensive stuff that they have to buy. It's intuitive. It makes sense, and it's graceful. Like a lot of the presentations for certain NFP methods, it was started by Catholics, so leave it to the church to make sex so unsexy, but not with Billings. It's like it maintains this nice graceful kind of like, yeah, that's what it should be. It's polite when you're talking about the body, and it's helpful. You understand it without getting impolite. So I like the course for that reason in and of itself. And you don't have to do temperatures all the time. Like you can actually, when my understanding was that taking temperatures, yes, it correlates to when you ovulate, but it's almost like doing unnecessary homework. Like you're getting an invitation to the party after the party already happened. Who wants that? Right. So you want the heads up that the party is approaching, so that, and if that makes sense. But
right.
I would recommend people really look at this method. I guess I'll put the link to the film. I don't want to brag about that, but I did participate as narrator for a film that talks about Doctors John and Evelyn Billings and their whole journey to discover natural family planning as we know it today, and how it's not like the rhythm method, and it's much more just rigorous scientifically, and fascinating story. And I think this audience would really appreciate that. And
yes, and I'll just add that it was the Billings who believed that it was keeping it simple is what makes it work so well. Yes. You mentioned temperature. There are, of course, many devices now where a woman can measure hormones and things. Of course, a phone app can be used with the Billings ovulation method too, just to record your observations. But sometimes that extra data doesn't make it easier. It makes it harder. Now, it doesn't mean that data from your health professional can't augment what you're doing as an individual. But I'm just saying, as an individual, having data overload is not always the best approach.
Absolutely. And Evelyn, she really helped to make it suitable for the everyday woman to think clearly about it and understand it. So her contribution to this was
enormous. Yes.
So Craig, is there anything else you want to add before we go? I feel like we could talk all day. I know I could talk all day and night with you, but we got to wrap it up at some point. So any kind of like closing comments?
Well, I'll just add that, the whole question of how the vaccine affects the reproductive system is very fluid. And even though there's some data that, there's pieces of the puzzle that say maybe it is safe, and there's lots of questions and underlying science that indicate that it could be harmful. That's the reason why it's vital that this is an informed choice for people. There's nothing wrong with somebody believing that the vaccination is going to protect them and their risk will be lower than if they get infected. But that's a big difference between being mandated or forced to take the vaccine or it being a condition of your employment. That's tyrannical. That, coupled with the loss of the medical research integrity, is very problematic. And I just hope and pray that we've learned from this experience. The amount of attention that we've given to this disease completely dwarfs the attention that we've given to other diseases, right? And if we focus this much attention on every disease process, it would put things in perspective, I think. But just think about, because I was in the field of orthopedics for a while, if I were to describe to you, because I've seen these, been in lots of these surgeries, not performing them myself, but assisting in the presentation of equipment. If you were to see what the woman has to endure when she has a hip fracture, especially, let's say, a more severe form of a hip fracture called a subtrochanteric fracture. And then the morbidity and mortality associated with that as a woman gets older. We would all be walking around with bubble wrap around our hips, and we would be having debates on what's the best calcium supplement to use. So I just want people to put that and put the COVID disease in perspective. There are many other things in human disease that need more attention, and we really need to just stop talking about it. We really do.
That reminds me of the famous statement from the founder of Merck, or president of Merck: "You don't sell a drug, you sell a disease." And I think that you're very right about putting things in perspective. So.
That's spot on. Yes.
Dr. Turczynski, I really appreciate your time, and I hope people visit BOMA and become teachers. Thank you for being with us.
Thank you, Alana. I appreciate the opportunity, and I look forward to the summit.